I'm Mike Render, and welcome back to this edition of Excelsior Foreign Profiles. No stranger to the show. We've had him back on, Dr. Sanjay Godhwani. He's a rheumatologist. Tremendous things being done in rheumatology right now. Anybody who has arthritis or joint pain might want to stay tuned and listen up. So great to have you back on here, Doctor. I really appreciate it.
Larry, thanks a lot for having me on the show, man. I love being here and excited to talk about some new things today.
Yeah, leaps and bounds from last time that you were on. The new research that's going on with arthritis is incredible. And some of the things that we're going to get into. One of the topics that we didn't touch on is this spondyloarthritis.
Spondyloarthritis, yeah.
Yes. What exactly is that?
Yeah, I think what you mentioned just now is like there's a boom in the field of rheumatology, and a lot of new things are coming out. A lot more research, a lot more development. One of the things that's been creating a lot of buzz is this topic and this condition known as spondyloarthritis. Now, if we just break the word down, spondylo means spine, and arthritis means, pain, tenderness, inflammation of the spine. One key aspect about spondyloarthritis that separates it from other arthritises is that it's also an inflammatory arthritis. Like rheumatoid arthritis. And sometimes people ask me, what are the different types of arthritis? How do you know which one we have? How do you know which one we don't have? So the term spondyloarthritis is like an umbrella term. And what I mean by that, it's a category. And underneath that category, there's little parts that come connected that kind of bring these different diseases that overlap with each other. And thus, this category is called spondyloarthritis.
Now, isn't all these diseases, aren't they all autoimmune diseases?
Yeah, so, and that's a great point to start by telling our audience about is what is an autoimmune disease and what types of arthritis are considered autoimmune versus wear and tear. I mean, the most common type of arthritis is osteoarthritis. And this is that wear and tear, athletes, construction workers, people who are doing repetitive activities. And over time, each joint has a little bit of cushion in between them. And over time, that cushion wears off, especially in the knees, the hips, the shoulders. And as a result, you get this bone on bone rubbing and breaking down that cushion. Now, that's osteoarthritis. Now, that's not an autoimmune disease, right? Some of the things that are considered an autoimmune disease are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. And the key difference of an autoimmune disease is, and the example that I usually love to illustrate it is when your immune system, and the immune system is very complex. And that's why a lot of the medications that are coming out, they're getting so detailed, so specific in targeting different steps in the immune system. So if you get a pneumonia, a UTI, the flu, your body's defense mechanism is set up in a way to say, listen, you have the flu, you have a pneumonia, your body's going to go and try and attack it. But in an autoimmune disease, there's an imbalance. There's an imbalance of the things that are trying to protect you versus what's trying to destroy you. And our body creates antibodies, like these are markers that we can test for in the blood, which will show that now instead of me trying to fight this flu off, trying to fight off this infection, something has stirred up within my immune system that's making my own body think that I am bad. And as a result, our immune system starts to attack us. And in an autoimmune condition, and such as inflammatory arthritis, which are all autoimmune, what happens in that kind of situation is it's a systemic disease. There's thousands of autoimmune diseases out there. Some of them, just a portion of them, contribute to rheumatology and also arthritis. There's things that can affect your joints, your skin, your organs. Sometimes they even affect your kidneys, liver, heart, all these things all together. So that's what happens in an autoimmune disease, where your defense mechanism is thrown off balance, and now your body thinks that there's something wrong. I don't know how to put this fire out. And some of the key things that people experience early with these kind of conditions are fatigue, like all of a sudden just gradually building up and not being able to get out of bed in the morning, finding rashes, hair loss, finding rashes on the face, skin lesions, getting palpitations, joint swelling. So a lot of different things compromise and make up with autoimmune diseases, and we're hoping to clarify some of these with the spondyloarthritis.
Now, also, I have to bring this up because we always get so many questions about it every time you're on, is the weather.
Yeah.
The weather does affect your joints.
Absolutely.
And a sensitivity to weather could be one of the signs of oncoming arthritis, right?
Yeah, well, listen, as we get older, I have my moments where my back and my knees start going now too. So as we get older, there is a capsule that surrounds every joint. And I like using the knee because I can illustrate it. Around your knee joint, there's a small capsule. And like I always say, when the temperatures change, 40 degrees down to 20 degrees, 60 one day, who knows what the weather's going to do tomorrow. But you sense that pressure, like the tires on your car, and you start the car in the morning, that tire signal is on. That capsule tends to expand and contract with the drastic changes in weather. And as a result, sometimes people will say, oh, I know it's going to rain tomorrow. I could feel that cold air coming. And that's exactly what happens. And during the winter months, this time of the year, people experience that.
So grandma's not crazy.
She's not, man.
Okay.
She's not. You got to stop telling her that.
Okay. Well, because we got a letter from a viewer, and her husband was saying that she's crazy because when the weather changes, she could tell.
Yeah.
And she's probably more accurate than most weathermen are right now.
Right, exactly. And the true holds also for the warmer weathers. So it's not just the cold. The same thing can happen in the winter when that damp air settles in, the humidity settles in, rainstorms. So a lot of times people do flare in the winter, right? We know that the cold air is not good for the joints, and sometimes it can make that capsule expand. However, in the warmer weather, the same thing can happen. And certain diseases flare in the winter, certain diseases flare in the summer. However, the key thing is to recognize when you're about to flare and to put that fire out and treat that flare as soon as we can. I got a question today at the office actually about what's a flare. What is a flare? And the key thing to understand is when you're presenting and being diagnosed with some sort of autoimmune disease, what you present with, joint pain, stiffness, swelling, rashes, hair loss, whatever the constellation of the things that have led you to see a rheumatologist leading up to a diagnosis, is usually what's going to happen when your body flares. So what I try to explain to people is if your joints start getting more stiff, if you're having a hard time getting up, your fatigue is settling in higher than usual, these are some of the things that can happen with a flare. Fevers, tiredness, sometimes maybe even feeling a little bit foggy at times.
Rashes, like you were saying before.
Rashes, all of that can happen in a flare. So that's something that the audience needs to realize, that if you're suffering with arthritis and you're noticing bouts, like you're good for 3 months and then all of a sudden something happens, there's a change in the weather, you got a flu or an infection, any type of stressors, job related, work related, school related, any type of infection, anything that's putting your body under stress, can it trigger a flare? And a big part about managing autoimmune diseases and arthritis in general is really what we're doing here, is just like counseling, educating our audience, and really getting the awareness out that if you're going through bouts of ups and downs and you're getting flares and periods, then it might be a good opportunity to talk to your primary care doctor, see a rheumatologist.
Now, we just finished up a series that we did with the spinal surgeon, Dr. Washka, and we learned quite a bit of stuff. He did a question and answer period. Now, it's different for what he does because he by the time you're seeing him, the damage is done.
Right.
Now, with the back, what are the symptoms? How would you really know?
Yeah, so a key thing that we should talk about is something known as the signs of inflammatory back pain. Now, typical back pain that we talked about, the wear and tear type, like, listen, I'm going to work, I'm on my feet all day, I'm pounding on some construction work. When you get back home at night, you're going to be in pain, right? As the day goes on, you're going to feel more pain. Some of the key things that separate inflammatory arthritis and inflammatory back pain is morning stiffness. Waking up in the middle of the night, usually after 2, 3 a.m., because that's when your immune system and inflammation system starts to trigger up. I get up in the second half of the night. I'm very uncomfortable when I sleep. I get up and I'm stiff. Like, being stiff in the morning is not normal for your joints. Understand that coming home after a long day of work, yeah, you're going to feel some pain because you've been working all day. But after a night's worth of rest, getting up in the morning, and usually if you have some type of wear and tear, if you rest, the pain gets better. In these conditions, if you rest, the pain does not get better. The pain actually gets better with activity. So the more you keep getting up and moving, that's when the pain starts to get better. And that should be a key thing to remember about inflammatory back pain.
Now, also, when we had the spinal surgeon on, he had talked about fusion. Now, you had told me before we had started the show about that people can have a complete fusion of their spine?
Right. One of the key things that I think is important for our audience is that arthritis affects all ages, the young, the elderly, and everybody in between. This particular type of arthritis that we're discussing here today, spondyloarthritis, one of the hallmarks of this disease is something known as ankylosing spondylitis. And essentially, ankylosing means fusion of the spine. And in this condition, when the inflammation starts, it does start in the low back, like around your sacroiliac joint, or like deep within your pelvis. You feel it deep within your lower back. And if it's left untreated, that inflammation process tends to start fusing up the spine and causes what's known as a bamboo spine, which is a complete fusion. Now, listen, this takes time to develop, Larry. We're not going to see somebody today and diagnose them with this complete fusion process. But the key thing to also understand that there's a delay in a diagnosis of almost 8 to 10 years with somebody with ankylosing spondylitis. And you're out there wondering, well, why wouldn't somebody get diagnosed with this condition if it can fuse your spine? And the key is that it affects younger people, early 20s, mid-20s, males more than females, but also females. And those are the kind of younger generations at work. They're
right.
busy. They don't see physicians.
Yep.
Maybe they're seeing a chiropractor. Maybe they're seeing an orthopedic. Maybe they're going to physical therapy. And everybody should have the awareness that if you're having this type of recurrent, like groundhog sensation, like I wake up, I'm stiff,
every day,
I got to stretch every day, I got to do this, I got to take some anti-inflammatories just to loosen up the pain, it should be something that should warrant further assessment.
Well, when we talk about all these different arthritis,
right?
How do you test for these? I mean, there's so many.
Yeah.
I mean, you could probably match what I think the word you used was asymptomatic. There's certain
Right.
symptoms that go
Right.
with certain diseases.
Yeah.
But a lot of these can fool you, right? Because,
Yeah.
like you said, it's the body fighting the body,
Yeah.
right? And depending on what area is getting attacked, kidney,
Right.
lung, stuff like that, it's got to be hard to make somebody's diagnosis, right?
Yeah, and again, the key is really listening. And as a viewer, as a patient, as someone that we're trying to treat and diagnose, what's really important is coming prepared, describing, thinking about all the symptoms that you're experiencing, what's hurting you, when it's hurting you, what you've tried, what makes it better, what makes it worse, and then us examining you. A solid history and physical exam is always the key and most helpful in trying to at least narrow down some of these conditions. And then listen, sometimes I ask patients, do you have psoriasis? And they're like, no, I don't know what that even is.
Right.
And I think we have some pictures of that. We have some pictures to show you these categories that make up the spondyloarthritis. But then I go digging into their hair and examining them, and I find psoriasis. And boom, that's your diagnosis right there, So really a careful history, physical exam, and of course the blood tests help, right? We got great technology. Again, I think science is wonderful. What's being made, and there's a new drug on TV every 5 seconds,
Right.
about something related to arthritis, and like I mentioned before, like this is a growing field. There's so much research going into medications, and we can do some really good blood tests, really accurate diagnoses can be made. And then we do a little trial, like, maybe we give some steroids, some anti-inflammatories, some muscle relaxants, just to see what's helping the situation. We get the blood test, we get some x-rays, maybe some MRIs. And normally in a wear and tear arthritis or osteoarthritis, which does affect the spine quite often, there's different signals on the MRI, different things on imaging that we can use to help and diagnose which type of arthritis it is.
Now, you had mentioned before about some of the new remedies and everything that are coming out. What about some of these natural remedies they're talking about? They're saying, like, if you eat certain foods, you're more prone to get arthritis.
Yeah.
Is that true, or is that old wives' tales?
Yeah, so let's bring this back to the spondyloarthritis, right? Like, so what's in this umbrella, right? So we talked about ankylosing spondylitis, the younger generation. Always look out if you're waking up stiff. Psoriatic arthritis, so that's plaque psoriasis. 1 out of 3 people with psoriasis develops psoriatic arthritis. Another major category in this group is known as IBD, or inflammatory bowel disease. This is patients who are dealing with Crohn's disease, ulcerative colitis. The disease itself is related to the gut, right? And all of these conditions that we're mentioning, they're all associated with the gut. They can also affect the eyes. It's called uveitis. So if you've seen an ophthalmologist and have painful red eyes that flare episodically, and the ophthalmologist has mentioned the word uveitis, anything with the word itis means active inflammation, that's also a part of this condition. But the gut plays a major role. Even if we're treating a lot of patients with one condition, there's a good 30% chance, 40% chance that they have some gut involvement. Sometimes people call this the leaky gut, or they call it like inflammation within the colon itself. And what we're feeding ourselves is really what's, you are what you eat.
Now, you had said too, before the show we had talked about, it was a very interesting case, was that you can actually have food allergies, like some people with gluten and stuff, go through your whole life and not know it, and then these things hit you later on in life.
Sometimes people are very tuned with their bodies. Like, they know, like, if I eat this, I don't feel well. If I eat that, I don't feel well. And they'll eliminate their own diets in their own way. However, like uncooked red meats, a lot of dairy, of course, smoking, drinking, all of that plays a role. But people do sometimes go unaware of these conditions till something else pops up. And with an autoimmune condition, you don't wake up one day and you say, oh my God, I think I have lupus, I think I have psoriatic arthritis. These are insidious. These things take time to develop. So it's like a 6-week, 8-week process, and they notice that things are changing along that timeline. And initially they may try to ignore it, take something over the counter, try some therapy and so on and so forth. But as that time gradually increases, more things pop up. So what we like to do is make sure that patients are keeping a timeline, make sure that you're aware of what's happening under what situation. And that's also helpful for us because we're kind of like detectives. We're trying to like put pieces together that, you might be seeing a cardiologist for one thing, a gastroenterologist for one thing, and you might be seeing an orthopedic for another thing. But if you take all of that history and put it into one container, shake it up, you might come up with one thing, or one diagnosis, I should say, that could treat all of those conditions.
Now, let's talk about some of the great stuff that's coming out there now. We have these new line of drugs, these biomedics, I believe they're called, that can really help patients suffering from different types of arthritis. Can you tell us a little bit about that?
Yeah, so first again, we're diagnosing, we're doing the blood test. So the initial visit is getting to know each other, running a few things that's going to help us get more information. And then that's that period that we're trying some medications. Now, once we've gotten a solid diagnosis that you have psoriatic arthritis, you have rheumatoid arthritis, spondyloarthritis, there are what's known as disease-modifying drugs, or DMARDs. Now, that's like the first step in treatments, and now that we're also developing and transitioning from that into biologics. So disease DMARDs, what they're known as, are disease-modifying anti-rheumatic drugs. It's pretty much a term that we use that classifies drugs for rheumatology, right? These are drugs that are targeting the rheumatic diseases. And I love this example also, is this inflammation, this fatigue, this swelling, this fogginess, this stiffness. Imagine that is being caused by like a fire hydrant, right? The fire hydrant is pouring out this water on you, and that water, when it's actually active and it's getting you wet, is the inflammation. Now, prednisone, steroids, or anti-inflammatories, what they do is they just put an umbrella in front of the fire hydrant. So now you don't feel wet. You feel good. You feel great, right? Because you're not getting wet. You're like, oh, great, I'm not in the rain.
But the water's still pouring out.
But the water is still pouring out. Exactly. And what the disease-modifying drugs do, and what these biologics do, is they turn that fire hydrant off. So now you're not needing steroids. Now you're not needing anti-inflammatories. You're being controlled with these medications. And biologics are that. Biologics are engineered and developed medications that target specific parts of our immune system. And I think it's fascinating what science is doing and how it's working, because in our immune system, maybe next time we can do a talk on just the immune system itself and break it down bit by bit. And I think it'll help the audience understand a little bit more about how these medications work. But imagine you're in an ice skating rink, right? And everything is moving in a smooth flow and motion. Everybody's going around having a good time. And that's what our immune system should do. Everything has a perfect harmony and checks and balance. Now imagine if we take somebody, give him some Red Bull, blindfold him, and throw him in the middle. You can imagine the chaos that could occur. And that's how the immune system gets activated. That's how that chaos starts. And then that one person hits another person, hits another person, hits another person.
Domino effect.
Domino effect. But now people start hitting the walls of the rink. That's inflammation causing joint damage. So what these drugs are trying to do, these biologics are engineered. They're composed of some human components, maybe even some animal components, but they target a specific molecule within your immune system and block it. So what they'll do is they'll take that blindfolded guy on Red Bull out of the picture, and they'll take away everybody else who was affected by it, so that your body can resume that smooth circular flow again.
So it's treat the target, like
Yeah.
you were saying before the program.
Yeah.
Now, with the future, they're saying that they possibly may even have a cure for it.
I hope so, man. I hope
the way
so.
things are going.
And another part of what I love to do is that, once you're diagnosed with an autoimmune disease or rheumatoid or psoriatic or spondyloarthritis, like, there's no cure. There is no cure to date for these kind of conditions, but we do have something known as remission. And remission is a term that we use to get you as close to disease-free as possible. And what you mentioned before, the treat the target, actually the ACR, American College of Rheumatology guidelines encourage us to be very aggressive up front. Because if we can put that fire out, we can turn that hydrant off as soon as possible, we're preventing permanent joint damage, we're preventing permanent skin or organ, we're preventing permanent damage. We're taking away that guy hitting that ice rink over and over again. And that's what the guidelines say to treat the target. And if we can do that as soon as possible, there is a chance that we can put the disease into remission. And you may possibly be able to go off of medications. Although sometimes these conditions do flare back up.
Yeah, so flares that you were talking about.
They do flare back up, but so I'm hoping there is a cure out there, and I really do hope that it's fascinating. It's fascinating.
I mean, yeah, just from the time that you were a student studying rheumatology to now, how many breakthroughs have been made?
There's, honestly, and I'm constantly reading about new medications and new targets. So right now we have different categories of biologics. Some of them all grouped up like anti-TNFs. These are the things you see on TV like Humira, Enbrel. They're always on. They're a group of medications in that category. And now we're coming out with newer categories. So if one or two medications in this category didn't work for you, listen, it sounds odd to say this, but 30, 40 years ago we had aspirin and prednisone and gold. And now we have a multitude of options. So I do tell patients, like, listen, don't worry. Like, yes, you've been diagnosed with psoriatic arthritis or rheumatoid arthritis or any one of these conditions. What happens is that we have so many different options that we can use to treat and control the diseases now. So if one doesn't work, we have other options.
Well, that's great. I'm glad you came back on to let us know about these new and improved drugs and therapies that are out there to help people. But we're basically out of time here, so I do want to thank you, Dr. Sanjay Godhwani, for coming on.
All right, Larry, thanks a lot.
And I'm hoping that we can get you back again. We can go
Absolutely.
over the immune system.
We got a lot to talk about. Whatever
the
audience wants to hear, we'll be happy to talk about it.
Okay. Till next time, I'm Larry Mike Arenda. This has been Excelsior Forum Profiles. Take care. Keep healthy.